emergency department, which is the first point of contact. The bulk of patients who live in hospitals, that is, who are warded in hospitals, come through emergency departments. And that means that if they were to be adequately treated, it would be best for the patient if the definitive care were to begin at the emergency department. Unfortunately, today, in India and in many other countries around the world, the people who staff emergency departments tend to be rather junior doctors with no proper training in emergency medicine. The advantage that emergency medicine brings is that it will give them the ability to diagnose, to identify what the main components of the problem that they are coming in with, and to initiate that care in the earlier phase of their illness or injury, in which case the likelihood of the patient turning better earlier is much greater. Unlike what happens today in India, whereby definitive care, the specialist who's trained in a particular illness, only comes in later when he's available, not attending to his busy outpatient clinic. And so those three main components, the first responder, second responder, and the trained third responder, if all three responders can come in at a much earlier phase in the development of disease or injury, then the potential for the patient to do well is so much greater. And I think that will impact positively on the cost of providing health care. So if you look at components of emergency medicine, it's not just something that exists within the hospital. It reaches all the way out into the community to when a disease first begins, to when the ambulance crew is taking care of the patient, and when the patient is initially seen in the hospital. The economics. Today, when we talk of paying for emergency care is regarded as a basic human right in most societies, and therefore they expect that the state should bear the costs of providing emergency care. Even if the state does so, when you think of what is the true cost of emergency care, the true cost is, number one, is cost to the patient who has to go through the sickness, go through the injury, go through the period of morbidity before he can earn money again by getting back to his normal role in society. And that has an impact on the family, because the longer the person is away from normal work, there's loss to the family income. Number two, cost to the hospital and the healthcare system. The longer a patient stays in hospital because he's not well yet, the higher is the cost to the healthcare system. And that cost can be brought down significantly if inpatient stay is shortened, and if outpatient stay is also enhanced significantly. Third thing is cost to the employer and cost to society. The economic cost of disease or injury is tremendous if the person who falls sick or is injured is out of action for a longer time frame. And how do you get a person to be out of action for longer time frames? To delay care. If you were to implement care very early, then you shorten the duration of morbidity, you decrease the mortality, you decrease the cost to the economy. So looking at it overall, therefore, emergency care and economic cost. The true economic value of emergency care is providing emergency care as early as possible, which means bringing in the first response, the second response, and the third response, all trained in as early a manner as possible, so that the duration of illness, morbidity, either because of illness or injury, keeping it as short as possible. Emergency medicine in India has come a long way. It was about 10 years ago, I think in July 2009, that the Medical Council of India formally recognized emergency medicine as a distinct specialty. Now, but by and large, the bulk of emergency physicians in the country are in the private sector, though the bulk of patients who frequent hospitals go to public sector institutions. I'm told that close to 70% of all hospital attendances are in the public sector. The bulk of bad injuries, cardiac arrests, are sent to public sector institutions. However, what's happening in the public sector is there are very few emergency physicians, trained emergency people. Most public emergency departments, which are often referred to as casualty departments, are staffed by junior doctors. Though there are so-called casualty medical officers who are specialists on duty, who cover the emergency department, they're not the first people to attend to patients, and they only come in when called to attend to patients in public emergency departments. So as a result, number one, there is no oversight of first responder care, because in the public there is hardly any first response capability today in India. Very few people are trained in the public. Number two, second responder care, emergency care, is also almost non-existent, because the ambulance service is by and large a transportation service, and in only very few instances is emergency care initiated on-site definitively before transportation begins. And because in most ambulances in the country there's only one EMT at the back, the single EMT is unable to provide any form of good quality emergency care except in very few instances. And thirdly, in hospitals, in the hospital sector, since the bulk of public hospitals do not have trained emergency expertise, and public training in emergency medicine for public hospitals is not yet in place, there's a lot of tremendous scope in India to improve emergency care for the majority of patients who come to hospitals.